It's wonderful to be here, especially at Inova Heart and Vascular Institute. I am a vascular surgeon, as Kim said, which kind of differentiates us somewhat from other practitioners that also treat and care for vascular issues such as cardiology as well as interventional radiology. Here, we're lucky and fortunate that the Heart and Vascular Institute that we don't really compete against each other. We work congruently with each other, and we think our outcomes as a result of that really manifest well for the area. So what we're going to do today is talk about one component of the circulation, which is the arteries. As we know, there's two components to the circulation. There's arteries and their veins. Today's talk will primarily be about the arteries, which carries blood from the heart to the rest of the body. If you have diseases of the arteries, again, the blood vessel that carries blood from the heart out to the rest of the body, it's a serious problem. Fully, most amputations that occur in our country, which is about 750,000 each and every year, are due to diseases that develop within the arteries of the legs. It's particularly important because there's thousands and thousands of people who have blockages in their arteries, in their legs, and they may not even know it. So they may not have symptoms, or the symptoms are what we call undersymptomatic, meaning that, yes, there are symptoms, but not severe enough to impact their life in a way to where they're going to seek treatment. And as a result, they end up modifying their lifestyle, which leads to other problems. And we'll discuss that as well with this next 30 minutes. If circulation problems in the arteries are not corrected, eventually it leads to what we call critical limb ischemia. Ischemia just means a lack of blood flow. And essentially, that's the most severe form of blood flow problems, arterial problems, and if not treated, you will lose your leg. And again, as we talked about, the majority of amputations that occur in our country are due to arterial blockages resulting in critical limb ischemia. At Inova Hospital, we are on the front lines every day throughout the health system, and we can make a big difference if we work together by informing everyone about the differences between normal leg pain with, say, aging, or abnormal leg pain that you get with circulation, or pain of the leg that maybe you could get because of lower back problems, or pains you can get in the legs from diabetes. We're specially trained to be able to distinguish them and treat them all specifically. This map is a map, obviously, of the United States, but it shows us the amputation rates per 1,000 people who are Medicare enrollees who are not diabetic. And for the most part, the darker the state is shaded, the more amputations per 1,000 people you have. You can see the Deep South has always and historically been one of the highest amputation rates geographically that we see.
Excuse me, Dr. Sam, I'm sorry to interrupt you. We're not able to see the slides changing.
Okay. It hasn't changed at all?
No, we still see the cover slide.
Let's see. Thank you. Oh. How's that? Is that better?
Yes, now we see the flyer. Yes.
Oh, I'm sorry. Thank you. I was on a roll too.
There we go. We can see it now.
Good. Thank you. Appreciate it, Kim. So again, here we go. This is the map of the United States, amputation rates. And as you can see in the area that we're in, which is in the DMV area, we have amputation rates almost as par as some of the highest rates that we see in the country in the Deep South. In Louisiana, where I spent some time working too, the amputation rate was almost twice the national average at 1.6 per 1,000 Medicare enrollees. So clearly, as you can see on the eastern Atlantic coast of the country, we have higher amputation rates than maybe we see in the Midwest or in the West, period. Did that change okay, guys?
It did, thank you.
Excellent, thank you. So again, peripheral arterial disease, it affects between 12 and 20% of all Americans aged 65 years and older. One thing we definitely see as we age is a normal hardening of the arteries. However, excessive hardening of the arteries and plaque deposition will again lead you to have diseases that could lead to either impairment in walking distance or in critical limb ischemia, which can cause you to needing amputations. As we see by age 50, fully 5% of people can be diagnosed with peripheral arterial disease. That number doubles to 10% by age 65. And clearly in people 80 years and older, we see that at least 1 in 4 individuals. For the most part, hardening of the arteries, we talked about aging as a process that contributes to it. But by far and away, the biggest comorbid condition that leads to the development of arterial disease is diabetes. Just having diabetes will increase your risk of having arterial disease by 4-fold. We see smoking almost triples your incidence of having peripheral arterial disease, as well as being either black or brown. And also hypertension and hyperlipidemia, which is basically high cholesterol, are also contributors to having these things. So usually in people with arterial disease, they have multiple conditions. They may be diabetic, smoked for years, or used to be a smoker, on blood pressure medications, as well as statin drugs, usually to treat their cholesterol. So it's usually not a one only thing that leads to this, but by far and away, diabetes is the biggest implicator of disease. We talked about this. When people have more than one comorbid condition, truly 6 in 10 people who have vascular disease usually have 2, 3, or more. In addition to diabetes, end-stage renal disease also. So if your kidneys aren't working well, especially if you're on diabetes, the increased calcium that we see in patients with end-stage renal disease causes hardening of the arteries, as well as those with diseases of the coronaries. Again, vascular disease not only occurs in the legs, but it also occurs in the heart. If it occurs in the arteries that supply blood to the brain and the neck, say the carotid arteries, it can lead to stroke. Fully 30% of all strokes are due to vascular disease that begins in the carotid arteries right here in the front of the neck. And when we look at how many people have vascular disease, here's what we see. We talked about 12 million people only behind diabetes and coronary heart disease as far as prevalence. However, out of those people who have peripheral arterial disease, we see their mortality in 5 years is much greater than people with just diabetes or coronary heart disease. Fully, once you're diagnosed with peripheral arterial disease, in 5 years, only about 7 out of 10 of those people will be alive. So that's a 30% mortality within the 5 years of diagnosis. And usually the implication of that, the cause of that, is either strokes or heart attacks. Because when you do have the arterial disease in the legs that can lead to amputation, it also gives you a good indication you may have disease elsewhere. So why is it a problem for us to diagnose, to treat? Partly it is because most of the first-line doctors who see people with vascular disease aren't the ones most in tune to treat it. That's why most of what we do as vascular professionals is just education. It's not unusual for your family doctor or your medicine doctor to be the first one to diagnose or at least hear complaints related to circulation. Same thing with podiatrists, particularly in people with diabetes. Usually one of the first things we'll see will be if you look on the toes, the hair may no longer be present. You may see thickening of the toenails. We'll talk about other signs later of the feet that you may see. Oftentimes the kidney doctors, they'll notice things in the urine that could lead for a diagnosis of peripheral arterial disease, as well as the wound care doctors, endocrinologists, as well as home health care people. So if you have all of these individuals seeing the sequelae of the disease, but not really understanding that what we're seeing is not a normal process, it's not a skin process, it's a vascular process. Oftentimes by the time we get them, things have occurred that may be irreversible. So that's why a lot of what we do as vascular specialists is educating our primary care physicians. The other problem we have is that there are several different specialists that treat vascular issues. Obviously, I'm a part of a vascular surgery group but we also have radiologists and cardiologists, and in some places, not in ANOVA, but in some places, these three specialists don't work together. And as a result, the messages given to patients may not be the same messages. The other thing too is that all three of these different specialists, we have different types of treatments that we can offer. Obviously, vascular surgeons can do surgery as well as interventions, whereas the radiologists and cardiologists primarily are limited to interventional treatments. The other problem we have with treating the arterial circulation is that there's really sometimes no real best way to treat someone. What I have here is a picture of us treating someone almost in the most invasive way that you can, undergoing a bypass operation. Now, the good thing about surgery is that it's probably the most durable thing that we have to treat vascular disease by using your own native vein to reroute your blood around blockages. But it comes at a cost. You have to go to sleep. These procedures take long periods of time. There's blood loss involved on some occasions. And then you have to heal up scars. So it's a lot to do, but it's the most durable way to treat people. And some people should probably have an open invasive surgery, but a lot of people shouldn't. As a result, the other way we treat people is with endovascular techniques, where instead of rerouting around blockages, we actually core through blockages with devices. Right here, we have a cartoon of one device which actually shaves away the blockage from inside. We have balloons and stents that can kind of squish the blockage to the side, and the stent can kind of keep it there and open up blockages as well. The good thing about these procedures, and I've done 3 this morning before our talk, is that it's not surgery. Incisions aren't needed. You don't have to go to sleep. You can go home the next day. The downside, though, is that for the most part, these treatments are not nearly as durable as surgery and oftentimes have to be repeated. Where we often have to repeat these procedures, particularly, is when we have long blockages that we see in the legs. And those are the ones that are typically going to lead to what we call critical limb ischemia, as we spoke of earlier. And those are the lesions that really make you at risk for losing your legs. Where the endovascular, meaning non-surgical treatments, are best is when people are impaired just from a walking distance standpoint. So we mentioned critical limb ischemia, and we'll go into it a bit more in detail now. It is the most severe form of PAD, peripheral arterial disease, that we see. It can manifest as ulcerations on the toes, as we see here. This can cause ulcerations on the inside of the legs as well as anywhere on the lower leg. It can result in thickening or loss of the toenails, and this can be oftentimes painful, particularly when you're trying to go to sleep at night. And as we talked about earlier, it can cause about 200,000 amputations a year, which is the #1 cause of amputations throughout the United States. But the one thing I want to leave you with today is that critical limb ischemia is also a marker for death. If arterial disease is allowed to progress to the extent that it threatens the viability of the leg, usually by the time we see that patient, their 1-year mortality is 20% and their 2-year mortality is 30%. Again, that's not really because of the disease in the leg. It's because the mere fact that the disease developed in the leg usually means the diabetes is not in control. High blood pressure is not being treated. Smoking is being continued. And so all of those different diseases negatively affects your heart as well as your brain. And usually that's the cause of death, be it stroke or be it a heart attack. So again, we see death within 3 months, 9% of people, heart attacks in 1, stroke in 1%. And sometimes no matter what we do, we can never restore adequate blood flow to the limb despite all of our best efforts, and thus amputation is required. We talked again about the different diseases that are in play. Coronary artery disease, which is the heart disease, stroke, which is diseases of either the carotid arteries of the brain, and what we're here for is peripheral arterial disease. And you can see all three of these exist in a fairly high percentage of our people that we treat. So that's why, even though we're vascular professionals and we want to treat the vascular problems, we always have to be in tune to what's going on in the heart, as well as what's going on with the diseases that can affect the brain, because those are the things that will lead to your death. We talked a bit about symptoms related to arterial disease. The one that affects your walking, we call it claudication. And it's really important that you hear this, because so many people think that having leg pain is just a part of aging, and it's really not. The quintessential complaint that you'll have when you have leg pain related to circulation is cramping of a large muscle group, either the calf or of the thigh or of the buttock, particularly when you walk. The typical complaint is I can walk 2 blocks, but after 2 blocks, I have to stop because I get a cramp in my calf. And if I stop for about 30 seconds, it goes away, and then I can walk again. And then usually after another 2 blocks, I have to stop. And that same complaint could be of the calf or of the buttock as well, depending on which blockage you have and where it's located. Some people, however, never really get cramping. It's referred to as fatigue. You know, my legs get tired. So that's something we also have to look at, because different people describe different symptoms differently. Tightness also is something that we may see, which is different from cramping. But at the end of the day, all of these things are not a normal part of aging. Other symptoms that we may see, and those people with diabetics, truly 7 out of 10 of them have what we call neuropathy, which is when the nerves don't do their job as well as they should and firing impulses down to the legs and feet. And usually that feels like a numbness, particularly of the soles of the feet, or like shooting pains. If that's been under control in a diabetic and all of a sudden it worsens significantly, that may be an indication that the circulation is worsening. So that's something we look for. One of the worst things that we see is what we call rest pain. And what rest pain is pain along the toes or the forefoot, so severe that it wakes you up out of sleep at night. And usually what you have to do is get out of bed, walk around, sometimes put your foot down, and the pain tends to go away. In some people with impotence, because again, the main cause of that oftentimes is a lack of blood flow in the pelvic arteries, that could be a sign that we see in people with vascular disease as well. There are some people who feel that if people just have the leg complaints where they can't walk or have limited walking distance, that, you know, we really shouldn't treat them because they're not to the point to where they're at risk for losing their legs for the most part. And for many years, we used to do that, just kind of watch those people, put them on a walking program. And at the end of the day, I mean, that was a valid way to treat people. However, what we noticed is that people's quality of life significantly changed when they were not treated when they had claudication. Unfortunately, before, we didn't have some of the options that we do today to treat people relatively non-invasively or minimally invasively, so they could go home within hours after a procedure. So at no point would you do a major operation for someone just so they can walk a few blocks more. But now you could very well do an angioplasty, which is the balloon expansion, or a stent, or an atherectomy, which is a coring out of a blockage, because it's a much less stressful option on a patient. Another reason why we would treat claudicant patients is because usually if you're only impaired with walking distance, that lesion, that blockage is going to be a minor blockage compared to the blockages that you get when you're at risk for losing your legs. So a lot of times we make the calculation that we should fix them now before they're more complex later. But the main reason why we want to treat you, even if you're only having cramping when you walk, is because if we can keep you active, if we can keep you walking, that's going to keep your blood sugar under control better. It's going to help your cholesterol be controlled better. It's going to keep your blood pressure down. And you're less likely to do bad things like smoke if you're walking around, exercising and moving, than if you're like sitting at home because you're having leg cramps when you walk all the time. The one thing we do know about claudicants, though, is that if you do have that, the overall prognosis really is not that great. In people who develop claudication, again, we talked about the 5-year overall 30% mortality, but that's all comers. But if you just look at kind of how people do with claudication, truly there's a 20% risk of heart attack or stroke, non-fatal. And we also see this 30% 5-year mortality. Again, 3 out of 4 of that mostly due to issues with the heart or issues with stroke. So again, risk factor modification, being active is why we want to treat you when you're only a claudicant, so you can be able to avoid the things to cause death. This graph here basically shows on the red bar, survival. So survival when your blood flow is pretty much normal is pretty good. The worse your blood flow is, the less your survival. So it's your ability to have normal circulation improves your ability to walk, which at the end of the day keeps you alive, which is the takeaway story we want you all to get from this lecture for the most part. We talked about lifestyle changes. We talked about activity level. This pretty much summarizes what those things are. Calf cramping, thigh cramping, buttock cramping, ulcerations, changes in hair texture on the legs. Those things could be, again, things that we look out to make sure that you need to be treated. We talked about the cool, dry skin on the legs. Those things often are the first signs, and why going to a podiatrist is oftentimes critical. We talked about thickened nails, almost like a fungus infection on the toenails. Hair loss or uneven distribution, not really from wearing socks like a lot of men get who wear dress socks every day, but particularly if you lose your hair on the digits, that's a big risk factor there and a big sign we may have some issues. Obviously, if you're weak, ulcerations or wounds are another big one. And the worst being gangrene, and we all know what that is, the black changes that we see on the toes that can really be problematic. How do we diagnose them? Well, we start obviously with what we talked about. The clinical examination. We look at the legs, we examine them, we do a pulse exam. But then the first line tests are really non-invasive tests where we take blood pressures all throughout the legs. Typically, your blood pressure shouldn't drop when you go from the thigh down to the ankle, but if it does, that's an indication that we have some circulation problems. We can also do ultrasounds where we actually look at the blood vessels and we can see in real-time ultrasound using technology with that you have blockages that are in place. We can also order more invasive tests like a MRA or a CAT scan as well, which can give us a much more comprehensive view of what we're dealing with and how to plan those things. This here is a diagram of pretty much how we do our ankle brachial index, which is the cornerstone of diagnosis. This can be done at your home. There are actually some kits where you can buy for this, but essentially this is what we do. We measure your blood pressure at your arm, and then we measure your blood pressure at your ankle, and we do a ratio. Most people should be either 0.9 or 1. The lower you get, the more disease you have, and it indicates that we need to do some treatments to improve that circulation. So what's our recommendation for screening? Well, we recommend anyone over the age of 50 with diabetes should get screened. And if you're younger than 50 but have risk factors such as smoking, high blood pressure, high cholesterol, or diabetes for more than 10 years, you clearly need to be screened, usually with an ABI. If it's normal at that point, those blood pressures are normal, then we can repeat that in 5 years. If that's not normal, then we need to see you and see you relatively soon. The American College of Cardiology, as well as the American Heart Association, they also have some guidelines. And because of the high prevalence of stroke, as well as heart attacks that are present in all these people with arterial diseases, we should actively look to risk reduce you by reducing your hemoglobin A1C and diabetes, by making sure you're on the proper drugs to treat your cholesterol and all those things. And we should do that because prevention is worth An ounce of prevention in this case is worth much more than any of the cures that we have. In a perfect world, we can put you on medical management only, but again, sometimes we have to intervene with endovascular therapies, as we talked about. And in the most severe cases, surgery, be it bypass grafting, unfortunately, amputations also must be performed, but hopefully those are things that we can avoid. How can we all make a difference, particularly you? Early detection is the key. We've talked about your family members, asking them questions, particularly our older family members who oftentimes don't complain, getting all of our people who we know who actually have risk factors that we discuss to make serious changes in their behaviors, because at the end of the day, the decisions that you make today will truly affect the life that you live tomorrow when it comes to taking care of your vascular system. It's a long road when it comes to treating people with vascular disease, oftentimes because there is no cure. It's a disease process that we manage. And education is important because by modifying your lifestyle habits, you will never develop vascular disease in more cases than not. However, if you do, we have to work closely together such that we can get you keeping your legs, keeping your activity level, to keep you to have a great quality of life, to be there not only for yourself, but also for your family. Thank you so much, and I'll be happy to answer any questions that you all may have.
Great, thank you, Doctor. I have a couple of questions that I see in the chat and then I see in the Q&A. And just a reminder, you can continue to put your questions in using either of those formats. And to get started, Champa, I see that Nancy has a question. So if you can go ahead and unmute her, Nancy will give you the floor at this time to ask your question to Dr. Sam.
Hey, Nancy, I've unmuted your mic. Are you? Nancy, are you able to?
She says she does. Nancy says she doesn't have a question now. So thank you, you, Nancy. Though. Okay, I'm going to go to this question here. If someone is on a blood thinner, is there a chance of getting PAD? Like Coumadin, is there a chance of getting PAD?
So the question is, does taking blood thinners prevent the onset of peripheral arterial disease? And the answer is no. So peripheral arterial disease, again, is a disease of the arteries, whereas the mechanism of blood thinners, it essentially prevents the blood from clotting to the same degree than if you're not on blood thinners. So now, part of the disease process does involve clotting. However, being on a blood thinner in and of itself will not prevent the development of arterial disease, and it's not a single line treatment for people who have arterial disease. Sometimes we use blood thinners in conjunction with other things, but as a standalone treatment, no, it's not a standalone treatment for prevention or for the treatment of arterial disease.
Great, thank you. Next question, is neuropathy a symptom of peripheral arterial disease? She goes on to say, I have neuropathy, but don't have diabetes, hypertension, and I don't smoke.
So the relationship between neuropathy and vascular disease. Again, we talked about neuropathy being abnormal functioning of the nerves going down to the leg, oftentimes manifesting as numbness or shooting pains. The cause of it, typically, we see is diabetes, because you have excess glucose, which is sugar circulating in the bloodstream, and that excess sugar causes the nerves to not function as well as they should. However, you don't have to have diabetes to have neuropathy. There's a segment of the population that just has primary neuropathy, and as a result, the treatments for that are pretty much a little bit different than they are for the diabetic people with neuropathy. We've recently developed many good drugs, even though I personally and we personally don't treat neuropathies, but Our neurology colleagues treat oftentimes with drugs such as Neurontin or Lyrica. Those are some really good ones there. Sometimes gabapentin. These are all drugs that kind of help the nerves function a little bit better. What we want to do in patients with neuropathy, though, is to make sure that their circulation is intact, because sometimes there's an overlap between the types of symptoms that you'll have with neuropathy as well as circulation. And we don't want someone with a circulation problem to only have neuropathy treated and not be realized that their issues actually are related to their peripheral arterial disease.
Great, thank you. Next question in the chat, and then after this, I will move to the ones that I see in the Q&A box. This one says, my dad, who's 82 years old, has peripheral arterial disease and is going for an angioplasty or stent. Not sure, but perhaps this Friday. I am 59, no diabetes, but my hips and legs sometimes feel weak. I'm not overweight, fasting blood sugar is 77, and on no medications. Am I at risk because my father has peripheral arterial disease?
So family history is a risk factor. Now, your dad is over 80, and so as we talked about earlier, we see 25% of Americans over 80 with some form of vascular disease. The majority of those people don't have to require treatment. Obviously, your father is on the other spectrum who has vascular disease and who needs to be treated. So by virtue of your family history, you do have a slightly higher risk of having disease, although your risk factors sound to be well controlled. If you see your doctor every year, by all means, they'll probably do a pulse exam, and which is all I would recommend doing right now, particularly if you don't have any symptoms other than the ones you described, which is just weakness of the hips and weakness of the thighs. And a pulse exam is very simple to do. It's not invasive. We just kind of feel your pulses, and if they're normal, then that usually stops. So that the short answer is yes, you're at slightly higher risk, but the main fact that your other comorbid, meaning your other things are in good shape, means that you probably end up doing pretty well.
Great, she said thank you.
You're welcome.
Next one, I'm going to move to the Q&A, and then we will get to the hands that are raised. This question says, in addition to health mention, can a clotting disorder increase blocks?
So the question is the relationship between clotting disorders and arterial disease. Good question. So we talked about earlier that blood thinners in and of itself is not really a primary treatment for treating vascular disease. Clotting disorders, meaning there are some people whose bloodstream clots too much than normal. They don't typically lead to the hardening of the arteries that we see. Actually, people who clot too aggressively have a more dramatic problem. They throw clots to arteries, and it causes a sudden loss of circulation, which if we don't address within 4 to 6 hours, can lead to permanent disability of the leg, thus requiring amputation. So the answer is no. Most clotting disorders won't really lead necessarily to the development of hardening of the arteries. But if a bloodstream clots abnormally, it could throw a clot to a leg, requiring a surgical emergical procedure to be done. Now, obviously, there's one caveat to that. There is one disease out there called factor V Leiden that may increase your risk of developing diseases down the road, but that's the only one that we know of.
Great, thank you. I have 2 questions here from 2 different attendees, but they're very similar, so I think you can probably address both in one answer. The first question says, how is PAD related to claudication? And then the second question is, I had claudication, it went away. I was told no new or other vessels took over. I have no PAD symptoms. Should I do anything or just monitor it? Okay. So how is PAD related to claudication? And then we have someone who says, should they do anything about it?
Sure. So how do your muscles work? So when you walk, your muscles require more blood than when you're not walking, than when you're, say, sitting or laying down. When your muscles, because your muscles need more oxygen because they're using up the oxygen that's there already at a higher rate because you're more active. In order to do that, the muscle needs to be able to get more blood. If you have a blockage above the muscle somewhere, and all of a sudden you start to walk or run or just get active, because of that blockage, extra blood cannot get to that muscle. And then when muscles are functioning without enough oxygen, that's when you cramp, because the muscle is telling you, hey, I need some more oxygen. You need to do something to get me more oxygen, either, or you need to stop walking because the muscle cannot continue to function without oxygen. And because you have blockages in the circulation above that muscle, that's why you get claudication. So that's the relationship between arterial disease and claudication and why it happens. Essentially, the blockages upstream from the muscle starve it from blood, which starves it from oxygen, which causes the cramping that we see in claudication. And there was a second part to that, right?
There was. The second part was this person was saying they had claudication, it went away.
Oh, that's it.
Yeah.
Yeah. So in most cases, claudication doesn't just go away without treatment of the blockages that are causing it. So what I would say is that there's a good chance that the cramping you had wasn't due to a blood flow problem at all, because there are other things that can lead to cramping of the muscles. Some medications can, particularly some high blood pressure medications can do that. Some electrolyte abnormalities, particularly low potassium, can lead to cramping. So if you indeed had cramping and then one day you didn't, it probably wasn't from your circulation.
Sorry. Next question is, what to do with a husband who complains about leg pain when walking but refuses to see a doctor?
That's a great question. And I wouldn't really have much experience with that because I listen to my wife all the time. But at some point, they'll reach a point to where the answer is going to be, do you want to walk to the doctor or do you want to lose your leg? And I think if that's the way it's presented in those dramatic terms, I think that'll get a change in behavior with your husband, that maybe they'll come in and see me in the office.
Great, thank you. Next question is, do you recommend a screening if you have no symptoms, such as an ultrasound Doppler?
Good question. So again, we talked about the American Heart Association, American College of Cardiology recommendations, but if you're over 50, diabetic, yes, you should get screened. And usually that's with the ankle brachial index, where we take the blood pressure of the arm and put it over the blood pressure at your ankle, or just with a cursory pulse examination by a vascular professional. So yes.
Okay. Thank you. Next question is, isn't there a risk of clots when scraping out the artery?
Good question. So yes, so endarterectomy, which was a term we had on one of the slides, which I didn't really go into, is when we do exactly that, when we clamp above, clamp below, open the artery, shell out the blockage, and then sew the artery back together with, or sometimes with a patch. And what happens is when you do that, it causes an exposure of some of the layers of the blood vessel that typically was not exposed. That's why whenever we do those procedures, we put you on blood thinners during the procedure, a really strong blood thinner called heparin. And then usually after the procedure, we put you on some milder blood thinners called either aspirin or some Plavix to help prevent that. But no, that definitely can be seen. Luckily, it's only seen in the minority of people since we've developed the drugs such as aspirin and Plavix.
Great, thank you. Can we go back to the topic of claudication, and can you comment on neurogenic claudication?
Excellent question. So the claudication we're talking about, again, claudication being cramping with activity, is arterial claudication, meaning because you have blockages upstream and you're not getting enough blood flow to keep up with the demands of your muscles activity. However, we also see claudication in people who have, say, back problems. Most of the nerves that go down to the legs and feet all originate in the lower back. So you can imagine a situation if you have a disc that's bulging or a disc that's too narrow, that's pressing on some of the nerves that go down to the legs and feet, that could give you very similar symptoms as if the claudication that we spoke about. There are ways to tease out the differences. For instance, if someone's having complaints of cramping and usually of the thighs and hips when walking, but have a completely normal pulse exam, have a completely normal ankle brachial index, well, then we start to think that it may be neurogenic claudication. And that's when we usually get them over to a spine surgeon to evaluate their spinal cord. So yes, they both can cause the similar symptoms, but there's subtle differences that professionals can do to tease them apart and get the right treatments, because it does us no good to say, have somebody with claudication, and we see this sometimes, that's due to to see somebody complaining of cramping of the hips and thighs, and then they get their spine work up, never get seen by a vascular specialist, undergoes injections, physical therapy, and then finally back surgery, and still have those same complaints of cramping, when all the while it was due to a circulation problem and not so much the back issue. So I mean, that's why it's imperative to be able to tell those two apart.
Okay. Thank you. The next question is, I have a possible aneurysm. The ANOVA director of vascular surgery has me on long-term Eliquis, 6 months. How does this relate to preventing the need for surgery for an aneurysm?
I'm sorry, what was the type of aneurysm? I missed that.
It just says I have a possible aneurysm. The ANOVA director of vascular surgery has me on long-term Eliquis.
Sure.
How does this relate to preventing the need for surgery for an aneurysm?
Yeah, typically, I doubt if your need for Eliquis is directly the result of you having an aneurysm, because we typically don't put you on Eliquis for treatment of an aneurysm. And for those of you all who don't know, an aneurysm is an abnormal enlargement and weakening of any artery. The main place where we see aneurysms are of the abdominal aorta, which is the main blood vessel that kind of comes off the heart, goes down the chest, splits at the belly button to send blood vessels to each leg. Right in the abdomen is where we see the vast majority of aneurysms. It's important to be able to diagnose them, because fully a third of all sudden death in men over 65 is due to aneurysm rupture because they've never been detected. Now, with that being said, being on a blood thinner like Eliquis isn't really used for treatment of that aneurysm. I'm almost with 100% certainty that your Eliquis is being prescribed for some other reason.
Okay, thank you. Thank you to the attendees who've raised their hands. We're going to go to those, and then we'll come back to the Q&A box. And I also see a couple of questions in the Zoom chat. So Chomp, if you can go ahead and start to unmute one at a time, we can take those questions live.
Sure. Stanley, I see your hand is raised. I will unmute you now.
Can you hear me? I don't know if my microphone is working.
Yes, we can hear you.
Okay, I have neuropathy. I had one of these neurological exams where they put electrodes up and down your legs, and all I get as a result from my Nova doctor was, you have a lot of problems. Well, I knew that before I went in there, and apparently it's very acute. As a result, I've had 2 ulcers on 2 different toes, and I was referred to the wound clinic. I'm a resident of a military retirement community in McLean, so I had to go to the nearest hospital, which was in Northern Virginia, and I was treated there, and I had to have nurses come to my home and change the wound. This was around Thanksgiving last year, but I've developed another toe that the other big toe. This was the right toe. Now it's the left toe, and as a result, that's just healed. You know, when is it going to stop? My middle toe and my right foot developed arthritis so bad to the first joint, the podiatrist was ready to amputate that first third of my toe. So I need to see someone today that can tell me, where do I go from here, if I can go anywhere.
So what you've had is what we call neurotropic ulcerations, likely from your history of having neuropathy. The test that you had to determine that you had neuropathy was called a nerve conduction test, and obviously it was not normal. Why do you get these ulcerations? Well, in people with neuropathy, again, we said that essentially is a disorder where your nerves are not conducting as well as they should from the legs down to the feet. As a result, you have to realize the nerves are actually constantly kind of making us like change positions with our legs and feet, because if we're in the same position for too long, you'll get skin breakdown in your feet. And it just happens automatically with normal nerve functioning, where you don't even know you're constantly shifting your position when you are on your feet. When you have neuropathy, oftentimes that ability goes away. And so you put pressure on different points of your feet in an excessive manner, and then you develop ulceration, not because there's a circulation problem, but again, your nerves aren't offloading pressure points in your feet. It's a problem we always have to deal with, because neuropathy, we can improve it, but oftentimes there's no cure. Working with a podiatrist is very important, because they can give you the proper socks, the proper shoes to maybe help offload some of those pressure points based on how you develop them. So I'm glad you're plugged in with the podiatrist. I know it's frustrating that there's no cure, but at the end of the day, we have to just manage that, much like we have to manage circulation problems sometimes.
Great, thank you. And thank you, Stanley, for your question. We're going to move to Art. We see you have your hand raised, and Champa's going to go ahead and unmute you at this time.
Art, I've unmuted your mic. You should be able to unmute yourself now.
Okay, I hope I'm unmuted.
We can hear you.
I had symptoms that made me concerned about PAD. It was primarily the foot and ankle pain when at rest. It would wake me up in the middle of the night and keep me awake and make me get out of bed. I took it to a podiatrist, and he examined me. He looked at my ankles and discussed my symptoms, and he concluded I did not have PAD. He said one was a result of a 20-year-old ankle break, and the other was maybe incipient arthritis. And my question is, should I go away and accept that answer, or should I seek a second opinion? And if I do, what specialist should I seek out?
Excellent question. So I'm always of the point to where you should always seek a second opinion if you have any type of doubt or apprehension. When I'm talking to patients all the time, if I sense that they have some skepticism, I welcome them to seek a second opinion, because at the end of the day, we want you to be treated in the best possible manner. Obviously, I'm a vascular surgeon, and I think the vascular surgery profession is the best professionals to treat and diagnose these diseases, because every single tool that's used to treat arterial disease, we are well trained in, be it surgical, interventional, or pharmacological. So I would always say, if there's a concern of circulation, by all means, come see a vascular surgeon.
Great. Thank you, Art, for your question. We're going to move to Gilbert. Gilbert, we see you have a question in the Q&A box and also your hand raised. So we'll go ahead and just take you off mute, and we'll let you ask your question live.
Yes, I have severe varicose veins in my right knee area, also some in the left leg, but the right knee area is the main problem. I've been experiencing pains now going on about 2-3 weeks around my knee that comes and goes, sometimes severe. Question is, should I come in for an evaluation? I'm 72 and I do control my diabetes. My legs feel heavy, toes are somewhat blue, but my primary care doctor says my foot pulse seems good. So just wanted to find out if I need to come in and have an evaluation.
It's almost like I planted you in the audience to ask that question. Wonderful question. So again, this talk was primarily on arterial disease, which is one component of the circulation system. The other component of the circulation system would be venous disease, i.e. your veins. So arteries carries blood from the heart to the rest of the body, and then that blood has to get back to the heart, and that's what veins do. So it's a different blood vessel, completely different from arteries, and they have their own host and family of diseases. And what you have sounds like you have what we call venous insufficiency. For every one person that has diseases of the arteries, there's 6 people that have diseases of the veins. They're much more prevalent than arterial disease. Fully 25% of women and 12% of men are walking around with problematic veins. It doesn't get a lot of notoriety because the vein problems are not as impactful as arterial disease. For instance, you won't be at risk for losing your legs because of a vein problem, more than likely. Arterial diseases are sudden, like a stroke, like a heart attack, like they happen suddenly and cause bad problems. Varicose veins are not like that. Venous disease usually has been around for a long time. You've managed it, but the symptoms are real. You've mentioned a few of them, which are classic: heaviness, aching, throbbing, almost like a toothache. Usually when you're trying to relax, you could have enlarged veins called varicose veins, like you sound like you do have. By all means, we highly recommend that you see us and you let us evaluate you so we can treat your varicose veins, your venous insufficiency. We have some truly earth-shattering treatments that we use for vein people now that we didn't have even 20 years ago. And we've completely changed the life of people with vein problems. I actually enjoy treating vein problems even more than people with arterial problems. And I'll tell you why. No one wants to come to me because they have an arterial problem. You know, no one wants to say, well, man, I need to go have this surgery so I can keep my leg. I need to have this surgery so I don't have a stroke. No one wants that. But truly, people want their veins to not bulge and bleed. People want their aching and throbbing to go away. So those things are a lot more satisfying to treat because the outcomes we have really can impact your life. So yes, I would highly recommend that you see us so we can take care of that. And I'd be more than happy to take you on as a patient.
Great, thank you, Dr. Sam. I see we have a couple more hand raised, but I'm going to go back to the Q&A questions that are here, and then we are going to wrap with the last couple of live questions. So the question here is, my vascular surgeon also referred my case to the head of hematology at Inova for consultation and review. How do vascular and hematology divisions at Inova Shar coordinate care?
Yeah, so when we as vascular professionals suspect that in addition to having diseases of the arteries, there's also aggressive clotting of the bloodstream. That's when we typically get consultation with hematology, because there are a host of genetic diseases that can cause problems, that can cause clotting, particularly after we've treated an artery. If we treat you and open a blockage and we have constant failure of a treatment, meaning stents that go down way too early, bypasses that fail when they should not have, that's when we always get consultation with hematology, because a lot of times that may indicate that that person has a clotting disorder, and then you can be placed on specific blood thinners to help prevent those abnormal blood clots from occurring.
Great, thank you. The next question is, I do have factor V Leiden and had 2 DVTs in my lower left leg. It was over 20 years ago, and I have been on warfarin since the diagnosis 20 years ago. I don't have diabetes and I'm not overweight. Are you saying my risk for developing PAD are increased?
Ever so slightly, just because you have been diagnosed with the factor V Leiden disease. So it gives you an increased risk of just having clotting problems. You've already had some on the venous side. What we've seen in long-term people with factor V Leiden deficiencies, we always just have to make sure that on the arterial side, they're not developing abnormal clots or are diseased inappropriately. So it's not a significant increase in your risk, but it is a slight increase in your risk. If you're doing all the other things correctly, I think you probably won't have those issues, particularly if you're still on the blood thinners.
Great, thank you. Next question. I sometimes develop a cramp in my calf muscle in pre-dawn hours, which awakens me. I must hop out of the bed to make the cramps go away. Could this be related to PAD?
So chances are not that they're going to be related to PAD, because, again, we talked about what causes the cramping, called claudication. It's when there's a demand in oxygen and thus blood flow that can't be met. So it has to be centered around an increase in activity. So if you're just reclining or laying in bed and you get a cramp, that's likely not going to be related to your circulation. Again, we talked about medications that could cause that, abnormalities in some metabolites in some minerals that can cause that, particularly potassium. But no, that's not going to be a circulatory cause of claudication.
Okay. Next question. Can macroanemia affect blood clotting in the arteries and feet?
So macroanemia, essentially what that means, and again, that's a hematological issue where you have an abnormality in your blood cells where your actual cells are larger than what they should be, and thus the bloodstream is thicker than what it should be. And what we can see in those who are not treated with macroanemia essentially is abnormal clotting, because again, the blood becomes more viscous because of the increased red blood cells that you have circulating. So although you don't get an increase in the arteries being diseased, you do get an increase in clotting because the clotting system gets activated inappropriately and too aggressively. So yes, you do get clotting more frequently, but that's not from disease.
Okay.
Of the blood vessels.
Great, thank you. Staying with the theme of claudication, can we get claudication in other body parts such as arms?
No, more than likely no. You can, but it's a rare situation. The arm is very different. So the arm has a lot of extra routes where the blood can flow. So a lot of times, even if you get a blockage in the main artery that fills the arm by the shoulder, you won't even know it, just because those other blood vessels kind of take over and every now and then there's a condition that we call effort thrombosis, where that artery clots because of like an aneurysm or something weird. And then if you use your arm, such as a painter who uses their arm a lot, and the demand is high, you can get claudication of the arm, but it's not normal, and we don't see it often. And in the big scheme of this discussion, the answer is no, we don't really see it in the arm for those reasons.
Okay, thank you. We're gonna wrap up. We see 2 more hands that are raised. So Champa, I will let you go ahead and take off the first guest.
Okay, I see Mahoon's hand is raised. I will unmute you.
Hi, this is Madhu here. I had a question, doctor. I have a mechanical valve as I had my valve replacement surgery 4 years ago. So I've been on blood thinner, and I've been lately having pain in my leg. I do have arthritis of the knee, but I've been having pain in my left leg, the lower below the knee. And it's so painful that I can't even keep my foot on the floor, and walking is very difficult. This is very recent for the past 3 weeks. So do you think it could be possibility of having a PAD since I'm on Coumadin?
Yeah, so your description of it sounds like it's in the front of the lower leg as opposed to in the back by the calf. Is that correct?
Yes.
Yeah. So, and it doesn't sound like it's associated with a particular muscle group, because in the front, you really don't have that. So although we couldn't say with 100% certainty, I feel comfortable saying that my thought of that being related to your circulation is pretty low, just based on the description of it, as far as location of it and what brings it on. So it doesn't sound like it's going to be a circulation thing, but whoever you end up seeing, just make sure they do a good pulse exam to make sure that's normal.
Okay. All right. Thank you.
Thank you and good luck.
Okay, our last caller is Steve. So Steve?
Yes, can you hear me?
Yes, we can. Thanks.
Thank you. Doctor, I'm the one who had a Q&A about claudication in my calf going away. It went away on its own, and I was told that it was due to a new blood vessel that took over the job and supplied the blood to the muscle. And I don't have any, I do have PAD, but I don't have any other symptoms. And is there any, should I just monitor the situation, or is there anything I should do?
So you had PAD at one point, and then, well, I'm sorry, you had claudication of the calf at one point, and then it went away. Is that correct?
Yes. Yes.
And you were told by your physician that a new blood vessel, for the most part, took over for the large one that was blocked.
Either a new one grew or another one took over the job. Yeah.
Yeah. So do we see smaller blood vessels grow once a major blood vessel is blocked slowly over time, as is in the case with PAD? Of course, we do. We do see smaller blood vessels that arise. However, those smaller vessels almost never, no, not almost, they never can do the job of the main vessel that it's trying to replace. So again, the mere fact that your claudication went away, makes me skeptical that indeed that was claudication at the outset. That may have been cramping due to something different. So
even though I have PAD?
Yes, even though you have PAD, and I'd like to know how that was diagnosed, if it was a pulse exam.
I think it was an ultrasound, but I don't remember.
Yeah, that's an excellent question, Steve. And I'd love to see you in the office so we can make sure you do have PAD, because I don't want you to walk around with that diagnosis if it's one that's erroneous.
It doesn't sound like I should worry, though. Is that right?
Well, I think you'll be okay, particularly if you're walking and staying active.
Yeah, I'm walking.
And not smoking. Taking
Right.
care of high blood pressure if you have it. If you're diabetic, taking your medication. And taking at least an aspirin every day, and maybe a statin drug for your cholesterol. I think you'll be fine.
Okay, thank you.
Anytime, anytime. I look forward to seeing you in the office.
Thank you.
You're welcome.
Kim, you're on mute. Kim? Kim, you're on mute. There you go. Nope.
Can you hear me now? Hey, can you hear me?
Yes.
Okay, sorry. What I was just saying was thank you, Dr. Sam, for this very informational webinar today. And thank you everyone for spending a little time with us this afternoon to learn about this important topic. And if you have any questions, Champa, my colleague, has put her email address in the chat. So if you want to capture that really quickly, go ahead and take that down if you have any questions for her. She's also put Dr. Sam's office number in there as well. So please take that down as well and give his office a call to schedule an appointment with him. And then after you leave today's webinar, you'll see a survey pop up, and we would just really appreciate if you could just provide us some feedback. And then within about 24 to 48 hours, you will receive a link to today's talk. And on behalf of ANOVA, thank you for joining us today. And we hope you have a great afternoon. Thank you again.
Thank you too.